We identified risk factors for allergic cross-reactivity among beta-lactams. We distinguished between common types of superficial and necrotizing soft tissue infections. And given a patient with a superficial skin and soft tissue infection, we recommended IDSA guideline-concordant treatment. Now, given a patient with a necrotizing soft tissue infection, let's recommend IDSA guideline-concordant treatment. To display the severity of necrotizing soft tissue infection, let's take a look at a few pictures. So there are 3 patients here. So panel A, C, and E are 3 different patients, and then they're showing you before and after surgical debridement. So although, when you look at panel A, it may not seem like a serious infection, but this is something that, unfolds very quickly. And what's going on underneath, so the necrosis is really happening underneath. So you can't really, see immediately how severe it is until surgical evaluation. And of course, the end result is that once they have removed, necrotic tissue, and manage the source of infection, this is the final result, which is extremely severe. These infections start with the usual symptoms of swelling, erythema, and pain, and what we look for is signs of systemic nature. So tachycardia, so essentially the SIRS, as well as markers of inflammation, so CRP. Elevated CK level can quickly indicate that there is a significant muscle damage, so myonecrosis is going on, and there is a risk score that we will not discuss here. But essentially, when necrotic or necrotizing soft tissue infection is suspected, the team essentially uses radiographic imaging to identify if they can see gas. And on imaging they can actually see if there is gas present or not, and that's one thing that's done very early, because if there is gas seen, that's something that essentially leads us to our clostridial species, whereas if there is no gas, that's more likely to be streptococci and other organisms. So if there is no gas seen on imaging, of course we do need surgical evaluation, incision, debridement, and of course specimen is always collected for culture and susceptibility. And so for gram-negative rods, if there are gram-negative rods suspected, essentially Aeromonas. So these are some of the water-loving organisms. So Aeromonas is found in fresh water. So, let's say somebody is enjoying nature outside, some fresh waters, and there was a skin damage, and Aeromonas found its way in. So those are some things that the team will ask if the patient has had exposure to fresh water, whereas Vibrio species are found in salt water. So if somebody's been, swimming in the ocean, where salt water, so Vibrio really can tolerate high concentration of salt. And also Vibrio vulnificus is something that you may hear on the news if somebody had severe infection, by simply eating raw oyster. So that's essentially oysters are coming from salt water, and they could potentially have Vibrio vulnificus causing severe necrotizing infection. For gram-positive, of course, we've talked about strep pyogenes, so that would be, one of the more common ones, but also Staphylococcus aureus, and these can produce toxins, so toxin-generating strep pyogenes, as well as Staph aureus. And then if you do see gas, so gram-positive rods, that's essentially Clostridial species. So there are different species of Clostridium, more commonly Clostridium perfringens. And this can be extremely severe, that goes to the level of myonecrosis. So it goes past, the soft tissue and find its way into breaking down the muscle underneath the soft tissue. So, and that's why, people look for gas early on to identify this. And of course, if, you don't suspect any of this, then you go the usual route of non-purulent skin and soft tissue infections, which include cellulitis, which we have discussed previously. So here are the IDSA guideline recommendations. So they do recommend prompt surgical consultation, and for patients with aggressive infections associated with signs and symptoms of toxicity, suspicion of necrotizing fasciitis and gas gangrene. Empiric treatment should be very broad. So these are, severe infections. So we don't mess around. So you want to cover your MRSA. So either vancomycin or linezolid. Linezolid gives you an extra advantage because it has antitoxin effect. So if you're, I personally like linezolid, but the general practice is that, majority of hospitals are using vancomycin, and then plus you need so this is broad spectrum, then you need a second agent to go with your MRSA agent. So piperacillin tazobactam is the most commonly used because you also want some anaerobic coverage because of the necrotic nature of this infection. And for that reason carbapenems are listed here. If somebody could not get these for whatever reason, an alternative is in addition to vancomycin or linezolid, you do combination of ceftriaxone and metronidazole. So I mentioned the anaerobic, so ceftriaxone doesn't have anaerobic coverage, so people would add metronidazole to ceftriaxone in case that's what they were using. And a good example would be if someone cannot tolerate piptazo, or if there is a shortage of piptazo and you wanted to avoid carbapenems and go to ceftriaxone and metronidazole. And every now and then there's also metronidazole shortage. And it's not uncommon for these infections to be polymicrobials, which explains why we need broad spectrum regimens. Now, penicillin plus clindamycin is the treatment of choice for documented group A streptococcal necrotizing fasciitis. So group A streps, so that's Streptococcus pyogenes, which 100% of them are susceptible to penicillin. So penicillin, drug of choice, proven efficacy and no resistance, essentially zero resistance to penicillin. And then you might ask, why do we need to add clindamycin here, where group A might actually be some of them resistant to clindamycin? And that's because clindamycin has the antitoxin effect, and we're dealing with a necrotizing fasciitis, so clindamycin will handle the toxins and penicillin will handle the organism making the toxin, because penicillin alone will kill the organism, but the toxins are circulating around, so you want to neutralize those with clindamycin. And here are recommendations for clostridial gas gangrene or myonecrosis. And the difference between necrotizing fasciitis and gas gangrene, essentially necrotizing fasciitis driven by streptococci and gas gangrene by clostridial species, so Clostridium perfringens. So the recommendation is urgent surgical exploration when gas gangrene is suspected. We do want broad spectrum empiric treatment, so we don't mess around. So vancomycin plus something that has anaerobic coverage, so piptazo or ampicillin sulbactam or carbapenem are recommended. And definitive treatment, once it's confirmed that it's clostridial myonecrosis, is penicillin plus clindamycin. And here's a slide from the guideline. So this is a figure from the guideline for non-purulent, which includes necrotizing fasciitis, right? So necrotizing fasciitis specifically will be under severe. So empirically, you want broad spectrum coverage. But then I want to bring your attention to the pathogen-directed part. So once your culture and susceptibility results are back, you can de-escalate from broad spectrum to pathogen-directed. So if it's Streptococcus pyogenes, we mentioned penicillin and clindamycin. If it's Clostridial, penicillin and clindamycin. If it's Vibrio, doxycycline plus ceftazidime. So here we're not worried about toxin production. Aeromonas is doxycycline plus ciprofloxacin. And of course, if it's polymicrobial, you just there's not much you can do, so you just maintain your empiric treatment, broad spectrum treatment of vancomycin plus piptazo. If you cannot pinpoint what's causing it, because these are severe infections, so patients can die from necrotizing soft tissue infections. So this concludes this presentation.